Now coming to the procedure of giving spinal anesthesia. As I said before, spinal anesthesia can be given in lateral position and sitting position. Now let's talk about lateral position first. In lateral position, there are two types of approaches, that is midline approach and paramedial approach. In midline approach, just as you can see on your screen, patient is supported by nurse at the edge of the table. Knees are drawn close to the abdomen so that spine is made prominent as patient sleeps in lateral position. Now you mark imaginary line joining highest point of your iliac crest, which is palpated on both the sides, and the imaginary line joining the two highest point of the iliac crest is corresponding to the L4 L5 space. Spinal needle is inserted after carefully palpating the space in the midline after raising a wheel with the help of local anesthesia. Needle is inserted in the middle of the space with bevel facing in upward direction. Remember, this is very important. In lateral position, while inserting the needle, bevel should always be facing in the upward direction. That is, bevel of the spinal needle should always be facing in upward direction. This is important because once you enter the interspace, you are going to pierce the ligament. The three ligaments which I mentioned before, you are going to pierce them and not cut them. In order to achieve this goal, that is to pierce the ligament, it is very important for the bevel to face upward direction and not facing it laterally. Slow and firm pressure is applied till a giveaway is achieved. When this giveaway is achieved, this suggests that you have entered subarachnoid space, and it could be easily judged by removing the stellate and see the free flow of CSF, that is cerebrospinal fluid. Once you remove the stellate, you see if the CSF, that is cerebrospinal fluid, is freely flowing. It should not be blood tinged. There should not be any blood clots present at the edge of the spinal needle. If now attach a clear syringe to the hub of the needle and CSF is aspirated. While aspirating CSF, again check if there is free flow of CSF. CSF should not be any blood tinged, or if at all it is blood tinged, whether the blood tinged CSF gradually clears off. Sometimes while giving spinal anesthesia, as you pierce the subarachnoid space, it is very common that you hit one or small venules, because of which a part of CSF or the early part of CSF may appear blood tinged, but gradually it wanes off, showing or suggesting that you are in the subarachnoid space and you have not pierced, you have not caused any problem to the subarachnoid space, and CSF is clear. But if at all the blood tinged CSF, which comes at the start of the flow of the CSF, is maintained, and the CSF which is coming out from the needle is continuously blood stained, you should think in terms of subarachnoid hemorrhage or any other complication that patient may have. If this is seen, that is the blood coming out of the needle is continuously blood stained, it is advisable not to inject spinal anesthetic solution in this particular space. You may try removing the needle, approaching the subarachnoid space at a higher interspace, say for example L2, L3 or L3, L4 level, and if the same thing continues, or if the same blood tinged CSF appears, you should investigate thoroughly the patient. You should go for CT scan and see if there is any other lesion present in the blood or in the CSF which gives rise to this type of blood tinged CSF, and abandon the procedure. But it is very and equally very important not to inject the drug when CSF is blood tinged. Now, coming back to the procedure, after you aspirate the CSF, when it is clear and free flow of CSF, inject the drug after confirming that the flow is clear. Remove the needle immediately after injecting the drug and adjust the position as per level of the blockade required, depending on the type of surgery, type of patient, and level of anesthesia to be achieved. Now, this what I described was a median approach. The other approach is paramedian approach. Just as I said, in lateral position given is same. Nurse standing at the edge of the table, patient is made to touch his knees thus making the spine prominent. Palpate both the sides of the iliac crest. Imaginary line joining the crest is at the level of L4, L5. And now the difference starts in paramedian approach. Needle is inserted not from the center but 1.5 centimeters from the midline of the space. Of the same space, but not through the center of the space, but 1 to 1.5 centimeter lateral or from the midline of the space. It is inserted at an angle of 25 degree towards the center. Rest of the procedure of subarachnoid block or spinal anesthesia is same as in case of median approach. Now, what are the advantages of paramedian approach? There are certain advantages of paramedian approach. First and foremost is it does not pierce the interspinous and supraspinous ligaments, which may be the cause of back pain, which patients normally complain after giving spinal anesthesia, that after say 1 or 2 months that patient complain of the severe back pain, and it is always blamed on anesthetist part that the spinal anesthesia which was given during a particular surgery may lead to this particular back pain. Actually, it is false. It's a fallacy. But it is very easy on the part of surgeons or gynecologists, whenever a patient comes to them post-operatively complaining of back pain, it is easy for surgeons and gynecologists to blame the game totally on the anesthetist, that it is just because of spinal anesthesia which was given previously. But studies have suggested that only 0.5 to 1% of patients may have back pain which is related to spinal anesthesia. However, to counter that 0.5 to 1%, paramedian approach is a safer approach, because in this approach you do not pierce supraspinous or interspinous ligaments, and flexion of back is also not important as you are giving the drug or as you are approaching the interspace laterally around 1.5 centimeter from the midline. In sitting position, the second way of giving spinal anesthesia, first is lateral position, as I described before, 2 approaches. In sitting position, same 2 approaches can be employed. Only difference between sitting position and lateral position is the position of the patient. That is, procedure is same as in case of lateral position, with only difference that patient is made to sit on the operation table with his neck flexed and back completely relaxed. Back is supported by the assistant or a nurse, and the same procedure with the same 2 approaches, that is median approach and paramedian approach, can be employed even in sitting position. And only difference between sitting position and lateral position is bevel of the spinal needle while injecting in sitting position should be facing laterally rather than facing upwards. It should face upwards in lateral position, but it should face laterally in sitting position. This is very important from MCQ point of view. What are the complications of spinal anesthesia? There are many complications, many symptoms which can see, but total spinal anesthesia is the most important complication. If level is not checked properly and is not maintained after giving subarachnoid block with the help of spinal anesthetics, this form of complication is very rare, but it is a major complication and can cause death of the patient if not judged properly or not monitored properly. So if level is not checked after giving anesthesia or spinal anesthetic, just as I had mentioned before, 5 to 7 minutes for injection xylocaine and 7 to 8 minutes for injection bupivacaine, if during that period position of patient is not maintained and level of anesthesia is not checked or level of blockade is not checked, the level might raise drastically, and once it reaches around C4, C5 level, phrenic nerve paralysis occur, and this can lead to total spinal anesthesia. What are the symptoms of total spinal anesthesia? It is very easy. You can diagnose it very easily. First and foremost is profound hypotension, which is not responding to normal whatever mechanisms or treatment which I had already discussed, like treatment of hypotension in case of spinal anesthesia. There will be profound hypotension in case of total spinal anesthesia. There will be respiratory paralysis because phrenic nerve, which is supplied by C4, C5, that will be paralyzed. And once the phrenic nerve is paralyzed, it will lead to respiratory paralysis. Patient will be unable to talk, and if still it is not checked or maintained, patient may land up becoming unconscious. Now, how do you treat total spinal anesthesia? Actually, it's very simple to treat total spinal anesthesia. The only complication in total spinal anesthesia is respiratory paralysis with hypotension. Patient is not able to breathe. So how do you treat that? immediately put endotracheal tube, intubate the patient orally, and ensure that proper oxygenation is done with the help of bag and mask. So immediate treatment for total spinal anesthesia is immediately intubate the patient. For this, any doctor, each and every doctor should know how to treat the patient or how to intubate the patient. Just as quickly as possible, and to do that you have around 90 seconds. Immediately do direct laryngoscopy, as I mentioned in previous module, intubate the patient and employ bag and mask ventilation so that proper ventilation is achieved and patient starts breathing, or you give oxygen to the patient till his respiratory paralysis is rendered ineffective or patient comes out of the respiratory paralysis. Along with the endotracheal intubation, what are the other things that you give? You start giving IV fluids to rehydrate the patient so that you can treat hypotension. You give IV pressure drug, just as I mentioned in the treatment of spinal hypotension. You IV ephedrine, IV atropine, and continuously ventilate the patient till the action of spinal anesthetic wears off, or till the phrenic nerve, which is paralyzed by spinal anesthetic drug, wears off. It will take around 1 to 1.5 hours, 1 to 1.5 hours, till such time that phrenic nerve paralysis wanes off. You are supposed to just ventilate the patient with 100% oxygen so that patient comes out of total spinal anesthesia. So, though total spinal anesthesia is very deadly complication, the complication of total spinal anesthesia, if not treated within 2 to 3 minutes, can be death. But it is very easy to treat it. You have to just intubate the patient and ventilate with bag and mask till the phrenic nerve paralysis, which is caused by spinal anesthetic drugs, wanes off. So this is how you treat total spinal anesthesia. What are other complications of spinal anesthesia? They are just simple normal things like nausea, vomiting, that can be treated with antacids and antiemetics. Headache, spinal headache is one of the complications. Some of the patients have around say 5 to 10% of patients have this problem, having spinal headache, which occurs in, as I said, 5 to 10% of patients. To counter that, the important method to treat this spinal headache is give high-low position and give IV fluid drugs post-operatively to the patient till such time that this spinal headache wears off. Even after doing that, if spinal headache does not wear off, the other and recently thought treatment module is injecting a blood patch in the CSF in the same space, but that is at a higher level. At our level, it is very simple and easy way to treat spinal headache. Give steep head-low position to the patient post-operatively and administer IV fluids. Spinal headache wears off. Now, other complication is backache, which occurs just as I said, which has been blamed on anesthetists by surgeons and gynecologists, that backache is a common problem after giving spinal anesthesia, though studies have suggested that that is not the case. But still, if at all backache is there, you can treat it with normal routine care and psychoprophylaxis. Retention of urine, whenever bladder paralysis, because bladder paralysis occurs till the spinal anesthesia wears off, urine retention occurs, and if more time takes for the spinal anesthetic to wear off, the abdominal distension can occur. But in case of abdominal distension, you should be sure whether that particular abdominal distension is due to retention of urine or some other. To treat retention of urine, it is very simple. You have to insert rubber catheter through urethra and just drain off the urine. That complication could be treated. Restlessness and hiccups, these are just anxiety related symptoms which can be treated very easily. And meningitis is a rare and very dreaded complication of spinal anesthesia. It can occur if proper care is not taken or proper antiseptic precautions are not taken while giving spinal anesthesia. This may lead to meningitis at a later stage. What are the advantages? Advantages are very, very quick and simple. Following are the advantages. They are like, it's very easier to administer, quicker, less skill and experience required. Only thing, you have to know what are the complications can occur and how you can treat the same. Better relaxation of abdomen. This is one of the advantages, because compared to epidural anesthesia or general anesthesia, the relaxation of abdomen is better in spinal anesthesia. Better control of height of block. Height of block could be controlled easily with the head of, adjusting the position of patient by giving head low or head high position. And dangers of toxic signs are negligible, because the toxic signs or the most dreaded complication of spinal anesthesia, that is total spinal anesthesia, I have already explained to you how easy it is to treat that. So these are the advantages. It is easier, quicker, less skill and experience required, better relaxation of abdomen, better control of height of block, and dangers of or toxic signs are very negligible. What are the contraindications? Contraindications for giving spinal anesthesia are severe shock. If patient is in severe shock, this is one of the complication or one of the contraindications where you cannot give or administer spinal anesthesia. The other contraindications are patient factors like severely obese patients. In severely obese patients, it will be very difficult to locate the L4, L5 space because of presence of fat at the level of spine. In kyphoscoliosis patients, due to obvious spine deformity, it may be very difficult to locate the interspinal space at L4, L5 level or L3, L4 level. Hence, these factors may contribute or may be taken as a contraindication. Severe asthma is a contraindication, because in cases of asthma, patient might, after giving spinal anesthesia or just piercing subarachnoid space, patient might land up coughing, and with that cough reflex, the drug which is injected in the subarachnoid space can just the level of blockade which you are supposed to achieve may not be achieved. On the contrary, it may increase. The level of blockade increases. So this can be treated as one of the contraindications. Neurological patients, for obvious reasons, patient may not be in perfectly conscious state, so you cannot administer spinal anesthesia in sitting or lateral positions. Unconscious patients, it's very obvious that you cannot administer spinal anesthesia in an unconscious patient. Clotting disorders is one of the contraindications. Whenever patient is suffering from any clotting disorder, it is very difficult to administer spinal anesthesia. And skin infection in the lumbar region. So it is very difficult to introduce spinal needle whenever there is infection of the skin in the lumbar region, as you are introducing the needle through the infection. This might lead to meningitis at a later stage. So this concludes spinal anesthesia. I have talked in detail about each and every aspect of spinal anesthesia. What are the complications of spinal anesthesia? How do you treat the complications? What are the different procedures employed? What are the different methods employed? And what are the different approaches that you employ for before and after giving spinal anesthesia? And I always prefer giving spinal anesthesia, and I always prefer it over general anesthesia or over epidural anesthesia, because it is very simple, safe, complications can be easily handled, and the relaxation or the relaxation which is required by the surgeon can be easily given to the surgeon without any problem. Even the surgeons are very happy with this form of anesthesia, because even after completing the surgery, by the time surgeon finishes his surgery, after 1 or 1.5 hours, the action of spinal anesthesia wears off and patient is absolutely fine. So for giving quick anesthesia, low cost and quick recovery, spinal anesthesia is better than any form of general anesthesia or any form of epidural anesthesia. There are some advantages of general anesthesia over spinal anesthesia or epidural anesthesia, but still, thinking in terms of normal patients, normal healthy adult males or females, rather than introducing cumbersome and costly procedures of general anesthesia or epidural anesthesia, I always prefer spinal anesthesia. Spinal anesthesia is way to go for all surgeries below T6 level. This could be done in a very proper manner without having any complication to the patient and to the surgeons. Thank you very much.